All right, so welcome everyone to this is our first NurseTOK of 2024, and we are very privileged to have the A team from actually four different time zones today, but all originating from Fiji, to talk about the setup and development of the pre-hospital emergency transport services in Fiji, both during COVID and how it's developed now into a few years later. So we have the lovely Dr. Maffa. You're first on my screen. Are you happy to introduce yourself?
Hi everyone. Kia ora. I'm zooming in from Hamilton, New Zealand, and it's lovely to have you all joining into our session today. I'm here on a clinical attachment, working in the Waikato Hospital Emergency Department.
Beautiful. Thanks, Dr. Maffa. And then next on my screen, we've got Shani.
Hello, everyone, and Bula. Like Beth has said, originally from Fiji, but I'm currently in Sydney, so I'm pursuing my Master of Emergency Nursing at University of Sydney. And I was in the tertiary hospital where Dr. Maffa was working during the second wave of COVID, and was involved in the pre-hospital retrieval coordination center at that time as well. So it's lovely to see everyone virtually, actually, after 1 year, I guess.
Cool. Thank you, Shan.
Thanks, Shan. So, Bula everyone, my name is Sheetal. I've been also working with Maffa and Shanestika in the pre-hospital retrieval center during the COVID second wave as well. At the moment, I'm working at the same location in NurseTOK Hospital with Dr. Elikini now joining in from Suva. And it's great to have you all here listening to us.
Bolo Manaka, everyone. Happy New Year. My name is Elikini, and I'm one of the doctors here at the emergency department. Initially was in Suva. Now I've spent just a little over a year now in the West. Happy to share our experience regarding setting up the hospital care coordination center. Explain a little bit before COVID, during COVID, and what it is at the moment. Naka.
Great, thank you all. And I'll just ask, we've also got Dr. Anne Cretan online as well, who was also very heavily involved with the development and setup of the pre-hospital emergency transport service. Can I just get you to do a quick intro, Anne, if you're not too busy? Thanks.
Hi, everyone. I was heavily involved in trying to press for a pre-hospital system, but I can't claim that I was involved in the setup of the system. I think it was a pure Fijian effort, and I was just lucky enough to witness it during my OSMAT deployment to Fiji.
Beautiful.
So hi everyone. Hi everyone. I'm an emergency physician, and I am now based in Cairns, Australia, but I spent 4 years living and working with these wonderful people in Fiji.
Perfect. Thanks, Dr. Anne. All right. So what I might just politely ask everyone to do, apart from the presenters, is if you can try and keep yourselves on mute, please, because we tend to get a lot of background feedback, which can interfere with the people that are talking. But please feel free, if you have a question, either pop it into the chat or unmute and happily ask your questions. But we certainly will have time for a chat later on after the discussion. Lovely. Thank you all, and over to Team Fiji.
So that's my time, Q. All right, everyone, I hope you can can see the screen, I am going to talk about how we set up the Western Pre-Hospital Emergency Coordination Center with the assistance of my lovely nursing colleagues, Shanestika and Sheetal, and with sound advice as well from our colleagues back in Suva, led by Dr. Ilikini. You can all see the screen. In terms of pre-hospital care, in the Western division, 50,000 people. There's 6 subdivisional centers, more like rural divisional hospitals, and the NurseTOK hospital also cover the smaller outer islands as well. And so if you can see the map, that's half of Fiji, that's basically the Western division. In terms of setting up being new to NurseTOK, everything was all quite new, the geography, the system, and the challenges were quite immense in terms of pre-hospital care. Even though we had police services, for fire services, there was a big gap in terms of the clinical aspect of things. We had police that would respond to incidents like motor vehicle crashes, and fire department would respond, to daily fire required services. But there was in terms of the emergency care system framework, it was a bit fragmented in terms of the clinical aspect of things, where there was no pre-hospital notification to the hospital. And apart from that was the care provided for our patients during transfer. So there was no monitoring, there was no continuation of care for our patients during transportation to the emergency system, to the hospital. And so the Western, if I say Western FAC, was part of the mitigation phase for the Western division in terms of our COVID response, looking at our colleagues in the Central division, where we were hit by the second COVID wave. It was devastating watching our colleagues in the Suva, in the Central area, managing the COVID outbreak. And so as part of our mitigation phase, a segment of our division commanding center was to set up an ambulance and retrieval center. And it came with challenges in terms of, one, the welfare. The 3 main challenges I faced were the welfare of the staff. 2, secondly was, this was an opportunity for us to advocate, to demonstrate the importance of pre-hospital care system. But how was I supposed to do that? Coming into a new hospital, into a new health service system, into a geography in which I was not aware of, where I did not know how to engage our other emergency service providers. So that was a challenge. And secondly was, how am I supposed to sustain, and how will I have accountability of setting up a Western pre-hospital care system? So at that point in time, this was the situation during the COVID pandemic. We were really short of staff. Our staff were deployed into so many clinical areas. Some of our staff had to support the Central Division with the outbreak. Our staff, with the limit numbers that we have, our staff were sent out to support the COVID ICU, and we had to move our department out into the car park so that we can continue supporting providing emergency care service, and at the same time protecting our hospital and the rest of the staff of the patients as well in the hospital. And I'd like to give the opportunity to thank the staff of the emergency department in NurseTOK Hospital. They really showed their grit in terms of providing emergency care service wherever it was required. And so we were requested to support this pre-hospital care system, and that would require more staff, leaving our services at the hospital depleted. So this was one of the challenge. The second was this: how do we advocate? How am I supposed to advocate for the establishing a pre-hospital care system? So this was the main building block for the WHO building block that helped us along the way in terms of making decisions to set up our pre-hospital, our FAC. It requires leadership, it requires infrastructure, it requires processes. So this was our go-to foundation in order for us to set up this service that was required for the Western Division. And secondly, because of the uncertainty of how this COVID outbreak was going to be, we saw like trends going up and down of our COVID cases, staff getting sick, being in isolation, their families. So it took toll of how are we supposed to support our services in terms of in the hospital and out of the hospital. My screen's frozen. So this is what I did. It took a little bit of planning. Unfortunately, I also had COVID, and it may be a blessing in disguise, because while during isolation, we had to activate a mitigation plan of setting up an ambulance and retrieval system. So it got immediately set up, but this was set up in the Western Commission's office, run by volunteer community, by people from the community. These were just people working as teachers, as fisheries. So they were manning this call center at the Western Division Commissioner's office. And just 100 meters away from them was the fire service. And so all the emergency services were in proximity, but somehow it was so fragmented that responding to the public calls was very discoordinated, and it put a lot of pressure on our staff, because our staff would be told to retrieve cases. They were not triaged, they were not properly assessed. And with our staff managing cases out in the department, it kind of put a lot of toll on them, because the public were demanding medical assistance. And so our staff were being sent out to see people with just a runny nose, or to retrieve patients who were in isolation, needed to be brought up to our emergency tents to be assessed and then taken back. And this put a lot of strain on it was overwhelming for our staff and resources and all that. So what we did was a surge capacity assessment plan. And this required good leadership from the top. We had to identify a channel of command. And so these were the main things that needed to be set in order for us to effectively set up a pre-hospital coordination center. We needed HR. We needed HR to monitor, to man the fleet, the call center, and also to respond, to do the retrievals. We needed fleet response vehicles. We needed to select a venue, and the venue was in order to select the venue, for me, the priority was our staff. Apart from the staff, it was to ensure that there was good access, good egress in order for us to respond efficiently. We needed administrative support. We needed phone lines. We needed to ensure that our staff had to be accommodated, and we things need to eat. And so meals was, like I said, we needed to make sure that our staff were looked after, not just for their physical needs, but also and to ensure that they do not get infected with COVID. And so this was all part of the surge capacity planning. It it took a very short time. When I got out from isolation, I think it took about a week for us to pull all our resources from our emergency service providers and make sure that we were able to set up our system. Now, setting up our Western retrieval system and ambulance retrieval system, these were the four main things that we ensured for an effective operation. And so first was the clinical care. There had to be governance over clinical care. We developed, and in that clinical practice guidelines, we described how we were going to operate the processes. We described the function of how we're going to use all our ambulance and response vehicles. We had a process on how to answer calls, receive calls, and destination planning, and as to how and where these patients who were requesting retrieval or medical assistance were to end up to. So we had all that process all set in line. And as part of that clinical guideline, we also had a training package as well, so that we could ensure that our responders, our staff at the retrieval system would know basic life support skills and know how to take basic vital skills. In terms of HR and trainings, as I've mentioned, because of the limited number of staff that we had to ensure that they're trained in basic life support. And during the operation, our numbers start to dwindle and the cases start to increase. And so to a point that our first responders, either the police, the fire services, or even our ambulance or hospital staff, were learning how to take and receive or give details using the IMIST format. With the limited numbers, we only had one emergency doctor, one emergency nurse, and the community staff manning the operation daily. And so to a point where the medical staff will be, our emergency doctors and nurses would be retrieving the critical cases, whereas patients that required hospital admissions but were not sick enough to require continuous monitoring during transfer, we had the assistance from our colleagues in the emergency services doing this as well. So it was quite a good experience running this operation system. In terms of vehicle and SOPs, part of our clinical guidelines were how we're going to division that covers 306 functional government ambulances, and our hospital only had two functional ambulances. And so every day or every alternate day, one of the things, challenges we had to face was the maintenance of our ambulances. And so these were part of the challenge. Porting ambulances such as fire or the private ambulance and such from Nandi Zen's clinic, we made sure that we had and they would only we made the decision
Matha, I'm not sure whether anyone else is
in between that will cut out the
Dr. Matha, sorry, you're breaking
Western
up a little
Division
bit.
as far
Matthew, I think your internet connection is becoming a lot more unstable, and we're finding it quite difficult to hear you. Maybe I think she's just disappeared. Yeah, I think she's just dropped off. So I think so far it's been quite a very in-depth discussion on the pre-hospital emergency care setup in the Western Division. Whilst Mafa hopefully tries to rejoin us, do you want to chat about? I guess there was a lot of similarities and differences with the setup in the Central Division as well in Suva.
Thanks, Beth. As Mafa has already mentioned, our pre-hospital care system are not as that well developed even before COVID, and this was mainly because the pre-hospital care is fragmented and there is lack of communication even among the hospital providers themselves. There are no specific practice requirements or training for providers, and poor patient records are maintained. There is lack of data on demand access, and also utilization of ambulances themselves. So basically, just to set the scene, even before COVID, we have a couple of ambulance providers, private ambulance providers in the Central Division. So if you want to call for an ambulance, they have their own specific number. We have the 911 emergency number, but these are usually routed to the nearest police station, and then you tell them what's your emergency, and then sometimes they route you to the ambulance providers. So these sometimes end up in multiple ambulance providers responding to the same call. In the Central Division, there's about 43.5% of the total population of Fiji that stays around the Central Division. This is about 385,000 or so population. We have 4 small hospitals, and we have a few specialized hospitals. We've got our main psychiatric hospital in the Central Division with our military hospital and our infectious disease hospital, which has our TB cases. So during the Fiji reported its first COVID case back in March in 2020, and then followed on with our community transmission later on in April 2021. Initially in the West, before we move over to the Central Division. So the setup of the pre-hospital emergency care in the Central Division was the learning we took from the outbreak in the Western Division. And what we did was that involving these private ambulance providers, we found it's a bit expensive. So we had a discussion with the government, and then we mentioned we've suggested that we have a lot of government ambulances that are available. So this includes the one with the military. They've got the one with the police, and also St. John was willing to help in, and also with the Fiji National Fire Authority. So we had a discussion together, and also at the same time there was a formation of the FEMAT, our Fiji Emergency Management Assistance Team, setting up the field hospital in the West. So we set up the pre-hospital emergency coordination center, and we reported directly to the director of the FEMAT back then. So the human resources for the FEC, we get personnel we utilizes the personnel from our security forces, from the police force, the Fiji Navy or Fiji military force. We've got correctional services. They also helped in. We've got volunteers from volunteer first responders, and also from St. John, who also pitched in, and some of our staff from the Ministry of Health. We help mend and run the FAIR Coordination Center during this period in the Central Division. So just a brief on how calls were taken during this period. So there was a toll-free line that was created, a 165, just something like a 911. So you dial 165 and then you say state your emergency. It was only during COVID. And then there will be a call taker who will ask you what's your emergency. If it's medical and if it's related to COVID, then there is a pathway for it. And if it's related, if it's non-medical, if you need your medications to be replenished, or if you need supplies, then they'll divert you to other options. So if you have any, if you mention that you have medical emergencies, then they log out, then they log all your demographics, including the symptoms and whether you've had any results, COVID results. And then this was assessed by one of the medical officer who is stationed at the call center. And then the medical officer will assess the case based on the severity. If it is urgent, and if it's an emergency case, then they will dispatch an ambulance together with the doctor to go and assess the case at home. And if it's non-urgent, then we usually pass it over to our public health team who does the follow-up. So the good thing about the system is that it is sort of a one-stop shop. They come, they assess you, and then if you need to come to hospital, they bring you to the hospital. But if you need to stay home, it's not that severe, then they'll just give you your medications and you don't need to come to hospital. Or even if you need some bloods done, they'll draw the blood and then they'll deliver the results later on. And so that was how the system was during COVID. So there's just a few challenges that we came across. So the challenges. So sorry, but just before I mention about the challenges, just we recorded a total of about 2,644 calls during this 4 months period. Out of these 2,644 calls, we had a 68% of these were cases that were calls that we respond to health facilities, and 28% of these were calls that we respond to, like home calls. And out of the home calls, 40% of them needs transportation to the hospital, while about 56 of them just need a follow-up at home, and then the medications were given, and then they'll be followed up by the public health team also. But unfortunately, at the end of our outbreak period, the FAC was dismantled. So there were several possible reasons for this. One is mainly the lack of substantial financial mechanism to maintain the system. The other one is the lack of political will to sustain and support a formalized pre-hospital system. And the other one is there might be existing existing ambulance providers. They may have competing interests that might hinder the establishment of a formalized pre-hospital system. At the moment, the FACT system still continues in the central division, but on a very smaller scale. But at least things are still, all the ambulance calls are still logged, and they at least can collect data, and then we can look at this data whenever we need to. Just a brief overview of. So that's a brief overview from the central division. I'm happy to take any questions later on.
Great, thanks, Dr. Ilakini. Has anyone got any questions before we move on to hear from Sheetal and Shani, who are two of our wonderful nurses that were heavily involved with the pre-hospital emergency care setup? All good. All right, over to you, Shani and Sheetal. Thank you.
Hi everyone, I'll just let Sheetal share screen. And thank you, Dr. Marfa and Dr. Ilakini for touching on pre-hospital retrieval systems and coordination center that we worked collectively in. What Sheetal and I are actually going to look at is nurses' role in pre-hospital care. And though we will touch on on COVID retrievals as well, but there are certain there's definitely pre-hospital retrieval systems that operate from the emergency departments in the mainstream hospitals, and nurses are still heavily involved in manning these ambulances when they go out to the communities to retrieve critically ill clients. So when we're looking at the role of nurses in pre-hospital care, we have to take into consideration the establishment of the pre-hospital care, and it is the first establishment or how pre-hospital systems actually or pre-hospital emergency care evolved was between 1960 to 1970, and this was in US, and I think this is mainly, if you look at the father of paramedicine, then it was done by Peter Seffer for cardiac cases and then later on for trauma cases. And then, of course, paramedicine in more developed countries is paramedics are the ones that are heavily involved in pre-hospital retrievals and going out and seeing clients in the communities. But in countries that are less developed and countries like Fiji, where I come from, nurses are the ones that man or attend to these calls outside of the hospital. And where, for context, ambulance officers are in Fiji are actually just drivers, so they're not trained in any medical or basically have any clinical skills. So they require a nurse or a doctor to be in these ambulances at all time when it goes out to the communities. Now, in terms of our role in retrieving these cases, well, where more developed countries have seen paramedics going out, but there are certain countries like Sweden, and this is a seminal literature that looked at the importance of nurses being in the ambulances, in the ambulances, even when the paramedics or medically trained staffs were there as well. And they looked at certain elements such as nurses who have worked in the critical care environment in intensivist care units or cardiology, and when they were working together with the paramedics, they said the patient outcomes were much better. And when we look at these roles, and I think it was very apt that it took emergency care or emergency systems to actually establish the pre-hospital care in Fiji, because obviously needs people with a vast experiences, with the knowledge that expands in not just one area, and also it needs individuals that can have seen cases, have worked under pressure, have worked in unpredictable environments as well. And so before I move into the trainings that have helped us, Sheetal and myself, and a lot of other emergency nurses that go out, Sheetal is just going to look at some of the roles that we played during the pre-hospital coordination center, in the pre-hospital coordination center during COVID.
Thanks, Shan. So my next slide, just going to be talking a bit on how we operated during our FEC retrieval center. At that time, when me and Shan, when we were told upon this role, we are a bit scared, and to think about operating something outside hospital. We've never been exposed to like public health or a pre-hospital setting before. So it was quite a challenge for us initially, with no formal ambulance system, no trained call takers. We had no guidelines or no trained pre-hospital providers, or no proper equipped ambulances to help us through and guide us through initially. So I think it was something that we had taken as a challenge as well. And we told ourselves, okay, let's make this happen and let's see how we can take on the challenge that's going to be for us nurses. And to take on the role was quite difficult, but then it was something that we had gone through each day. So these are some of the things that we initially had started on. What we did was that we tried to outline some of the activities that we need to do before we actually start running the pre-hospital retrieval system in NurseTOK and most of the western side. So what we did was, our team had come up with some educational training packages where we looked at some of the important areas that we had to identify that our team had to go through before looking after the patients. So we did a little bit of BLS training with how to use AED with Dr. N in the picture. You can notice that she's teaching us on how a BLS training to the military people, and some people are coming in from a voluntary response center, and also teachers that had also volunteered in the call center. And we had fire people and police coming in as well. And some of the things we also taught them was like basic taking of vital signs, simple taking blood pressure, saturation, or temperature for the patient, and what does it mean when those vital signs come up. And our main important thing was our safety, which involved, and we ensured that our PPE and the infection prevention control measures were up to par so that we can be safe to deliver the services to the public as well. And which actually started off with a few trainings, and later on we had used ISBA to teach them how to hand over patients from home to the required hospital or the health center that they were transferred to. And later on, you can see on the screen is a little bit on what we did was preparation part, which is ordering and replenishing of resources in the stocks that we needed. So this was the setting that you can notice was just basically it's a common room where we used like a classroom to stock up of all our stocks accordingly on the stacks, so that we can easily be available and to ensure that the replenishment is done every weekly basis, and also on the medications and the equipments that we needed for our retrieval. So we had places set up and ensured that daily use of the equipments and medical resources were checked, and then it was replenished so that we can have safe equipment, safe medication provided during our retrieval times. And you can notice that there are certain areas that we had to use the ground for our decontamination area. That's the tent. You can notice at the green tent at the last fourth picture was the area that we used as a decontamination area, and then we used basic rubbish bins and garbage bags where we had to replenish those stocks, and that areas that were effective for us to use during decontamination as well. And some of the other things that we usually do is our main process was when the FEC started was the process of how we could receive and transfer patients from their home, or what our main thing was to provide the best care that we could during that COVID times. So what our first picture you can see in the arrow was we had our volunteers, teachers, or some of the people that are involved from the forestry that had come in to help us take the calls. So we usually received calls from the toll-free call center number, and then the calls come through, and then we had to filter and triage and see if that calls were a retrieval call, or it was just basically giving advice through telephone. So this is where we had introduced telemedicine, and this is where we had actually first time used telemedicine as one of the things that we had advised over the phone, and we were able to give medical advice because there's a doctor and a nurse always assigned in every shift during that calls. So once the calls has been received in the center, we usually triage them over the phone and then identify the type of fleet or type of people that need to go and actually retrieve the cases. So you notice that we have actually used different types of fleet. We have ambulance, we have used a four-wheel drive vehicle, and also we have retrieved cases from the outer islands using a chopper as well. And after the calls has been transferred to the fleets has been dispersed, and the caller, the receiver, will inform our receiving hospital regarding the cases that are coming in. So usually the process of them being informed using a ISBA tool and a telephone guide, that we are able to inform them the type of case that they're oncoming on their way, and that they are supposed to be ready for what is what they're going to hand over. Because sometimes we had cases that did not have a medical personnel going and retrieving the cases, and we just had police or a fire person going and receiving the cases, and we usually let them know of the process. If it's a stable patient, then only they go and receive and transfer the case, and a sicker patient would usually need a more experienced medical personnel. So if there is no medical personnel at the FEC area, we could always take a doctor from the emergency department to go and retrieve the case as well. And once the case has been retrieved and sent across to the hospital, the next screen is where all the data entry happens, which is a very big job in the data entry. Usually we used a form of an online system, which was a jot form, to enter all the data that we had received from patient being received, and when the dispatch was happened, and where the care had been stopped. So all our data entries came back to the office, and then we had to complete the data in our daily reporting system. So once the reports had been collected, we had to ensure all our main bosses, so that will be like the hospital, divisional health commissioner centers, our Western Division center had to receive all the data daily regarding the number of cases that we had seen and we had retrieved in the day in daily process. Yeah, I think most of the things were involved. Most of the things were involved regarding our retrieval process, and this was our main part of our daily activity, where we did most of the retrieving of the cases. And yeah, I think I'll just, yeah, that will be from my side. I'll hand over to Shan now.
Thanks, Shital. So I think that was very thorough, and I think a bit of what we had done for FEC during that time. But I think what we were able to do was, and you know, that we felt confident enough to do, was because of the training that we had received while being in the emergency department. And I've worked, been in the emergency care in the emergency department for the last 9 years, and so has Shital. And during that time, we have had the privilege of being invited and being participants in a lot of trainings around pre-hospital care as well. And I think the main bit has been the MIMS and the HMIMS courses. And I'm not sure if the participants are familiar with this, but these are mass casualty response courses in and outside of hospital as well. And the first picture actually shows you tabletops where they teach you basically your communication, receiving and reporting of incidences, and your mass casualty triage processes as well. And I think these are the basic courses that give you a bit of an insight on how you need to respond, not just to COVID responses, but you know, mass casualty incidences where you are actually asked to man or go in ambulances and actually assess casualty incidents or casualty events and report back to main hospitals or report to other emergency services as well, and how to successfully and in timely manner triage large number of casualties as well. And apart from that, it has been trauma trainings where simulations have helped you build that confidence as well, and also your experience over working in casualty space has actually developed your confidence to respond to these things as well. And of course, basic life support has been a huge part of is a huge part of pre-hospital care as well, because a lot of calls that we do receive come from out of hospital cardiac arrest as well. And not only have we taught nurses or emergency nurses or other clinical nurses, but we have gone out and we have taught a little bit to the communities as well, non-medical personnel as well. And for those who are not familiar, Fiji does not have that many AEDs out in public accessible places. And so not a lot of public is aware on how to use these things. And so there's always, of course, there's always an AED in the emergency department. And whenever there's an ambulance call, then a nurse is expected to take that across with her and use that. And that is something that we have tried to teach our ambulance officers as well, that who can then assess as two rescuer rather than just one to help in such cases. As well as apart from that, just basic airway trainings as well has helped a lot of nurses in managing these clients and just escalating care while they're in these ambulances. And just like Dr. Marfa has said, we do cover a large area as well. And being in a tertiary hospital in Lautoka, I think we cover for more than 350,000 of the population. And though there are smaller hospitals around, the maritime retrievals, the chopper retrievals and going out in the boats is actually, just for the main hospital, the main tertiary hospital, and the nurses are the ones that are, or the doctors are the ones that actually go and do these retrievals. And I think it may be quite similar to other Pacific Island countries where pre-hospital systems may also not be as established or may not be established like ours as well. And I think just apart from the trainings, I think one thing that what Dr. Ilakini has said, there's competition from the ambulance service providers across, and that has caused a resistance or a friction when it has come to establishing a professional body or decentralizing ambulance services. But I think for nurses in this space, if you are someone who has been in the profession for long, has had the experiences, and if you've climbed the ladders and have reached that that place in that hierarchical leadership or management role, I think your role or your ability to network with the stakeholders and the management and the administrators is going to be very key. Is going to be the key that is going to unlock and help you decentralize these services and actually ensure that it is sustainable then. And I think another aspect is that we are so, that we burrow ourselves into clinical practice and think that our nursing duties are only limited to our clinical roles. And we sometimes shy away from being players in the political role as well. So health politics and being a key player in that area is very important. Understanding, how the politics work and how it drives the health services that you actually are working or the health organization is very, very important as well. Because though we may be moving towards more aiming for more transformational leadership styles in our clinical space, but I think there's still a lot of hierarchical styles in the more management level. And I think recognizing that and just finding your way through that helps in establishing such important services as well. So those are some of the things I think. There has been a lot of literature and a lot of things that have been said about nurses. There's a need for nurses to move up and say that they need to be heard in more political arenas as well. And I think it is for such causes like this. So thank you.
Great. Thank you, Shani. Thank you, Sheetal. And thank you, Dr. Marfa and Dr. Ilakini. That talk certainly highlighted the absolute grit, determination and passion that you all have for setting up a service in extremely difficult times with limited resources. And I think just to hear about how it's impacted sort of the future of emergency care is also really quite inspiring. So thank you very, very much. Has anyone got any questions or comments for our four presenters today? maybe whilst people are thinking, I think I have one to all of you. So I think it was Sheetal maybe that was talking about how much data you had to, or data you had to collect during the operation of the emergency care service. What have you done with that data now?
Can I give this to Dr. Marfa to answer?
Yeah,
Because I know most of the data that we had collected, we had submitted. I do not know exactly where did it go, but Dr. Marfa will be the best person to answer that.
Can you hear me?
Yeah.
Hello? Can you hear me? Can help Sheetal that question. So every analyzed in terms of because I had to do an administrative report we have the DCC meeting every morning, and so that data assisted us in pushing behind the scene, ensuring that our staff operating the Western FAC had meals, we had consistent supplies of medical resources. We were also using that data to push for IMT support, the incident management team from the Ministry of Health responsible for COVID, the COVID response. So those data assisted us in terms of our budget finances. And so it allowed the LauTOKA Hospital to claim whatever resources that was used to run this operation, because it was not part of the LauTOKA Hospital budget. But we managed to recover some amount of finance from the ambulance run resource. We focused on the expense that LauTOKA Hospital the LauTOKA Hospital provided, and so we managed to, in terms of budget and finance, we managed to summarize that up, and the medical superintendent of the LauTOKA Hospital used our data to retain and to get back whatever financial cost that was used to operate our FAC. And yes, and because we had daily data, it also gave us the opportunity to make our clinical decisions, whether we needed to continue to run the FAC or whether we need to stand down. And so with our daily data, one of the challenges was the JOT form. We didn't have the IT technical expertise to analyze and to put in all this data, but we were fortunate that one of our interns had this hobby, and so he assisted us with that. And we were able to analyze our dispatch time. We were able to analyze the type of calls, the amount of costing that we that was required in the day. And so it took a lot of personal sacrifice in order to get this JOT form done. And I thank Sheetal for doing her pro bono service. But eventually, there was lots of personal sacrifice into as well running this in terms of finance into running this. And so yeah. I apologize. I lost connection with everyone, but it takes good leadership in order for sustainability, and good data collection, good data reporting will enable collaborative support. And because of this data, we continue to have our support from the three leaders from the clinical services, our medical superintendent of the LauTOKA Hospital, the divisional medical director in the public health, and the commissioner himself. And so with all these daily recordings, they were kept up to date about how we were responding to the service and how we were achieving our objectives. And that was key. We were meeting our rapid response retrieval objectives. And so that's how we were getting our assistance. We didn't get that same attention as our colleagues in the central division was in terms of the ambulances and equipments. But with that information that Sheetal and Shan were collecting and making sure that we had every day, no pressure, but it allowed us to function and run effectively. And thank you, Sheetal, for doing the hard work in our data collection. Yeah.
Great, thank you, Dr. Martha. Dr. Ilakini, have you got anything to add with regard to data collection from the central division?
So with the data that we collected from the central division, this was all recorded on Excel database, which was later analyzed. And I think I used this data to do my master's research, and Dr. N is taking the lead and helping out in trying to get this published. So fingers crossed, and it's look promising. So with all these data being collected, we hope to, at least now we have a baseline, and it's all recorded, ambulance demand and how we were able to meet the demand, and from different health facilities and from different areas in the central division. And then hopefully this can push, so not only push, but make our people at high level make well-informed decisions about formalizing our pre-hospital system.
That's awesome. Congratulations, Dr. Ilakini. And I guess that really does highlight, you know, I think we, you know, in all of our jobs, we have to collect data. And I'm going to make an assumption that no one gets especially excited about that. But in order to make strategic improvements and changes, what Dr. Ilakini just told us was how important data collection is for future projects. So thank you very much. Any other questions, comments from anyone else?
Can I say something, Beth?
Absolutely.
So thanks for everyone's talks today. I hope the audience got a little bit of a snapshot of the enormous effort and leadership and collaboration that went on in Fiji, kind of getting a system up from nothing really during a pandemic. So great, amazing people, and really glad to hear their stories. Yeah, just to watch this space. There will be a publication coming out, free open access, which hopefully we can share in the next few months about the central division and some of the data. And if you will just humor me, I just want to read a line from our conclusion in that article. So in the emergency care system, human resources, training, infrastructure, equipment, and processes are like planets orbiting the powerful sun of leadership and governance and its companion moons, financing, and data. Pre-hospital systems depend on political will, leadership, and accountability, sustainable financing, and performance data. Disasters shine a spotlight on emergency care, and this can positively impact system development. So I really hope that all your efforts during COVID can be used as advocacy to continue to build your systems all across the Pacific. As we all know, it's a struggle to get the political will and the finances, but certainly I think this goes a really long way and presents a very strong case. So thanks to everyone for today.
Yes, and thank you all very much for all of the time and effort you have put in, and also to our participants as well for finding the time to join us. And hopefully we look forward to seeing some more people join us next month in February. We normally aim for the third Thursday of the month. So we'll advertise that hopefully with a little bit more warning. very shortly. So thank you all very much, and hope you enjoy the rest of your days. It's been fantastic and very informative.
Thank you.
Thank you.
No problem. We'll see you soon. Okay. Thank you. Bye. Bye. Thank you.
Sorry, Beth, you lost me halfway. I'm like, okay, I have to try and get back in.
No, that's all right. Your internet connection was very dodgy. You froze quite a lot.
Oh dear. Well, anyway,
No.
it's the Wi-Fi here. I don't know.
It's okay. It happens. And you're in New Zealand.
I know. Like I thought my Wi-Fi thing is okay because like streaming videos and all that is very fast. Like we watch Netflix and that's